I'm Nathan Orians. I'm a member of the Law Review's Executive Board. I'm honored and excited to introduce to you Professor Field and Dr. Shea. Professor Field is a nationally known expert in healthcare regulation and its role in public policy. And the students here at the law school are lucky to have him be one of our professors. Recently, he has worked on health reform and its effects, ethical issues in vaccines, and policy implications of genetic databases. He's a prolific writer and an important contributor to the healthcare field. In school, he was an associate editor of the Columbia Journal of Environmental Law. I mentioned this to note and to appreciate his career-long support of student engagement in the legal field through our journals. Dr. Shea is the Director of Policy and Analytics Center at the A.J. Drexel Autism Institute, where she is also an assistant professor. Dr. Shea has led autism-focused projects across Philadelphia and nationally. She's an author and a researcher who uses a strong evidence base to form, evaluate, and implement social and health policies. Dr. Shea has a doctoral degree in health policy from Drexel University and a master's degree in social policy from the University of Pennsylvania. A huge thanks to both of them for presenting their work today, and I'll turn it over to them.
Okay, I will start out. We will talk about the important role of Medicaid in providing services to patients with autism and to their families. I will give a little bit of background on the Medicaid program, where it came from, and most importantly, the waiver process through which states have flexibility to provide community and home-based services, such as those for autistic individuals. And then Lindsay will talk about research involving the actual use of those services and the eligibility of patients and the ways in which they are able to maintain their eligibility or lose it as they age. Okay, a little bit of history. The Medicaid program actually traces its origins to 1960 in the Eisenhower administration, when a program was launched for indigent elderly for hospital care. It was very limited, but it was an important step in federal assistance for insurance coverage. In 1965, it was expanded into the Medicare, along with the Medicare program as part of the Social Security Act. And it provided care to those in 4 categories that I'll mention in a minute, for a range of services as a partnership between states and the federal government. In 1981, the opportunity for waivers was expanded. Waivers meaning that the federal government would waive some of the requirements on states that limited their capacity to innovate and the kinds of services they could offer. This led to states adopting managed care to administer their programs, which is now the case in most states. And then in the 1990s, there was greater use of demonstration waivers to attempt new approaches, and recently a trend towards trying to impose work requirements on recipients. I won't go into that. And in 1997, Medicaid was supplemented by the Children's Health Insurance Program, which provides coverage to children and families who are a little bit too affluent to qualify for Medicaid, but not affluent enough to afford private insurance. The structure is it's a federal-state partnership. So the federal government provides matching funds anywhere from 50 to about 3/4 of the cost, sets parameters for what the states must cover, and then the states have the option to participate or not. The last state to participate was Arizona, which waited until 1981. Originally, there were 4 categories of recipients: pregnant women, children, poor elderly, and disabled children and adults. That varies in many states, but today most states have expanded their programs under the Affordable Care Act, which means everyone up to 133% of poverty, even adults without children in the family, qualify. There are 2 basic categories of benefits. The categorically needy get basic services. Most states expand that to what are known as medically needy, and they add additional services, prescriptions, eyeglasses, long-term care, and importantly, early periodic treatment and diagnosis, which is extremely important to Medicaid to autism patients. The expansion under the ACA provides coverage, as I said, for beneficiaries in any category up to 133% of the poverty level. Under the Supreme Court ruling on the constitutionality of Medicare, of the ACA's expansion, 38 states have accepted the expansion. It's actually 36, and 2 are in the process of considering it. And here's a map showing which states have expanded and which haven't, and you can see the pattern. The South and Midwest are the areas that have not yet expanded. And you can see for states that have not expanded, the income eligibility varies widely. So this is extremely important to those who might want services for autism or other areas that are not part of the categorical coverage, ranging from Arkansas, from Alaska, which is the most generous, down to Alabama, which covers the parents of children up to 18% of the poverty level. And again, you can see the variability in income limits here by state. So enrollment in Medicaid and CHIP together is 73.5 million people as of this past May. It's gone up substantially since the expansion. What that number means is that almost 1 in 5 Americans are covered by Medicaid. So it's an important mainstay of our healthcare system. And you can see graphically the way enrollment went up after 2014 when the expansion went into effect, and has remained at slightly above 70 million rather since then, and is ticking up recently and probably will go up substantially again because of the current recession. And you can see here the states with the highest enrollment tend to be those with the highest populations. Pennsylvania, being in the middle, is still an important state in terms of overall Medicaid and CHIP enrollment. So the first kind of waiver, which comes from the 1960s, are Section 1115 demonstrations. They allowed states to start using diagnosis-related groups for hospital payments, to begin experiments with managed care, and to begin providing home and community-based care as an alternative for institutional care. And more recently, to consider work requirements. You can see that middle bar for behavioral health waivers under Section 1115. Almost all states have some kind of waiver. And that is important because it is so heavily used for developmental disabilities and autism. In 1981, Section 1915 waivers were added, and this is where most of the home and community-based autism services are provided. It was considered, and obviously is, more efficient than institutional care. After the Olmstead decision, the uptake of these waivers increased dramatically since states were under pressure to offer non-institutional care, and they cover developmental disabilities such as autism. Section B provides freedom of choice being waived for managed care programs. In other words, under original federal requirements, patients have to have freedom of choice to go to any provider. Managed care restricts that. So states are able to waive that requirement to allow managed care to administer their programs. Many states have combined Section B and C waivers to provide home and community-based services through managed care. So you can see on the right in this chart the number of states that have waivers under Section 1915C. In Pennsylvania, there are a number of services that are available. Waivers for autism come into several categories. They all cover diagnosis. They do not have age limits. There are financial eligibility requirements that vary. Pennsylvania has a loophole that allows families with incomes above the poverty level to qualify, assuming children don't have incomes that are above the poverty level. And these are some of the services that are available. Assisted technology, behavioral support, family and caregiver training and support, nursing, physical occupational therapy, and transportation. So that is the basic landscape for the way Medicaid provides services for developmental disabilities and autism. And now Lindsay will talk about how that has played out in practice.
So there are several reasons why examining the experiences of individuals who are on the autism spectrum in the Medicaid system matter. Medicaid data generated from the Medicaid system can allow us to watch people over time, as well as across different providers and the services that they can use. So when we think about research applications, studying autism in the Medicaid system has many benefits and opportunities. There are several reasons why we think and know that autism is important in the Medicaid system. We know that, and this is a snapshot from one of our Life Course Outcomes Research Program indicator reports. We know that employment outcomes are poor among young adults and adults with autism, meaning that they are more likely to rely on Medicaid for medical coverage and for service access. Even though private insurance mandates have been passed in all states, they are all age limited and do not follow individuals during the critical transition into adulthood. Further, reinforcing that Medicaid becomes a particularly important player as individuals are aging into adulthood, where they'll spend most of their lives. We also know that even when individuals have private insurance as a child, as an adolescent, or as an adult, that there are severe restrictions on the services that are provided through that system, despite parity laws being in place. Medicaid is among the only options for individuals to receive home and community-based services that allow for employment support, community-based service access, and a range of other services, as Rob described. So this figure shows us that although individuals with disabilities or diagnoses are about 15% of individuals enrolled in the Medicaid system, they account for almost half of the cost in that system, meaning that there are tremendous expenditures and high rate of service volume allocated to this group, again allowing us to understand and observe through claims generated from the Medicaid system what services they're using, and that gives us a good sense of what is successful versus what services may continue to be needed. We also know that Medicaid serves a diverse range of Americans. So on the figure on the left shows us a pie chart of US Medicaid enrollment in fiscal year 13 as compared to the US population in a similar year, 2015. And enrollment in Medicaid is more diverse than the US population. And that matters a lot for autism research because we've struggled in this field to include individuals from racial and ethnic minorities in research studies in ways that could approximate or in any way approach representation of their needs and their experiences. So Medicaid data, again, allow us a unique portal into potentially accessing these groups and getting a unique glimpse at what they may need. The Medicaid system and data from it have been used to examine outcomes across a variety of adverse experiences and health issues. So this is an excerpt from a paper focused on foster care involvement, which is one category of Medicaid enrollment or eligibility that is an option. And when we look at the summary from this research, when children with autism were compared to children with intellectual disability enrolled through the foster care mechanism, both the prevalence and risk of foster care involvement was the greatest for the children who are on the autism spectrum. So this again indicates not only that these outcomes are increasing, that we need to study them in order to try and prevent and improve them, but also that Medicaid is a key system and a key way for us to really get a sense of what's going on. So the range of services that Medicaid funds for autistic individuals also is an important lens through which we should view opportunities in the Medicaid system. So across multiple service types, all service types, in fact, in this study, which I was fortunate to be a part of, all services were funded at a higher rate in the Medicaid system. And as you can see in the p-value column, in almost all cases, that difference was statistically significant. I would also highlight for you the magnitude of these differences is astounding when we look at total healthcare costs, psychiatric care costs, in particular outpatient psychiatric care, which we know is a primary modality of intervention for individuals on the spectrum. Rob also mentioned the enrollment patterns. So we can't study service use unless an individual has actually gained access to the Medicaid system. And some of the new ways that we've begun to think about and talk about autism have impacted eligibility criteria across the nation. This is a study that began to track Medicaid enrollment among children across the US using Medicaid data, so data straight from the Medicaid system. And it demonstrated that the number of individuals enrolled in receiving care through Medicaid increased dramatically. When we update this number using some of our newer data from 2008 to 2012, you can see that this is increasing even further, and that we're also seeing some shifts in the categories through which individuals on the spectrum are eligible for Medicaid. And these are themes to some of the work that we are engaged in right now. This figure shows the change in the age distribution of enrollees on the autism spectrum. So this is, again, total number of individuals of 0 to 64 enrolled in Medicaid, and we've used the color concentration to show you the distribution by age, which is a little difficult to see specific granularity. But when we look at these distributions, adults over the age of 30 have the largest proportional increase in their enrollment in Medicaid when we look at the total age of individuals enrolled. And this is a new article that we just had published in Psychiatric Services using the same data, where we tracked and sought to update the previous figure you saw based on enrollment of children on the autism spectrum, with a focus on transition age youth and adults. And so you can see the largest uptick in this top line are individuals ages 18 to 24. We also see increases across all the other age groups among adults on the spectrum when we use this data to look at who is enrolling. And that's really important because most of the research on autism has focused on children, including our research that has really leveraged data from the Medicaid system and focused on Medicaid system issues. And that research is much needed and should absolutely continue. I think the problem is that we've not built a parallel set of an evidence base for adolescents and for adults. And as you can see, the range of work that's been done also focused on children, from the 1915 C waivers that Rob described to Medicaid spending, has been quite robust. It's now our job to age that work up. Some of our previous work has sought to capture exactly these differences. So this is a paper where we used data from the Medicaid system to look at transition age youth on the autism spectrum compared to youth with intellectual disability to look at their enrollment patterns. And we found that more than 1 in 4 adolescents with autism lost their Medicaid eligibility during the transition to adulthood. Fewer than half of those who lost their eligibility or enrollment regained it. And the adolescents on the autism spectrum were more likely to disenroll than those with intellectual disability. When we looked at adjusted analyses using these results, the category through which a person was eligible for Medicaid was a very strong predictor of if they would disenroll as well as if they would re-enroll. And so as we think about the mechanisms by which people become eligible for services and the services that they receive, this is again a plot of the number of individuals enrolled in Medicaid from the years that we are currently focused on. And what you can think about is this uptick that we see in children continuing to age, because we know that the autism spectrum disorder diagnosis persists throughout the lifespan for the vast majority of individuals. So this issue, this opportunity is not going away, and it is indeed a set of policies to support this robust program that we need to study and begin to put in place to support their needs for the long haul. There are dramatic changes coming to those home and community-based services that Rob described, which are really key, not only to individuals on the autism spectrum, but to many individuals who are enrolled in Medicaid by virtue of a disability. So there's a quote unquote final rule, which is not really a final rule because there are many final rules in Medicaid. But this rule that is set to take effect in 2023 will change the face of how community-based services are provided. There's a wonderful guide from our partners at the Autistic Self-Advocacy Network, who I was pleased to see we're presenting earlier today, that tells you more about the final rule. One of the things that this rule will do is it dictates expectations for how much time individuals should spend in the community. And that goal is laudable. It's based in our deinstitutionalization movement and our continued shift into really prioritizing and focusing on community-based services for all individuals. The problem is that autistic individuals may have specific ways that they want to be involved in their communities, or specific service and support needs, particularly those that might be delivered through the Medicaid system that we've not yet gathered an evidence base to understand. And without that evidence base, we'll be formulating policy, benchmarking, without their input, decreasing the chances it will be successful. And involving autistic individuals in this research and in these policy recommendations is a really critical piece of what we must do moving forward to involve them directly. I value Medicaid data. I think it's an important way we can understand these needs. I think interpreting results and engaging autistic individuals in research questions is a very important part of how we need to move forward as a field. And once we have this research, it's even more important that we take extra steps to move it into policy, to not have it only live in our academic journals, to think about new applications, such as some of the innovative work that we've been engaging in with the School of Law and through this law symposium, to be able to really focus on the needs of autistic individuals, whether they're receiving crisis services because they've had a criminal justice system interaction, if they're looking for home and community-based supports to improve employment outcomes, or just to be involved in their communities in the same way that we all strive to be in normal times. We really need to spend time ensuring that we are translating our research findings into policy and communicating directly with policymakers and supporting autistic individuals directly in doing the same. So we're grateful for the funders who have invested in this work. We're proud to see Councilmember Green will be presenting later this afternoon. He's been a real source of learning for us around policymaker needs and ways that Philadelphia has been leading the pack to improve outcomes among autistic youth and adults. And I think we'll now take questions.
The ACA is found unconstitutional by the Supreme Court. What will this mean for all the people like these children that are covered under the ACA's expansion provisions?
Yeah, the waivers would not be affected. That is states providing coverage for categories of people who were not in the original Medicaid and for services like home and community-based care that were not in the original list of services. Those in states that have expanded, particularly adults who are now eligible for coverage, not through the waiver, would definitely be affected. Maybe Lindsay knows how many people receiving these services are getting them not through the waiver, but through regular Medicaid. But some subset of people would be affected.
Right, and Rob, I think we estimate that approximately 40% of the autistic population is receiving services outside of those disability-specific mechanisms and could be impacted by changes to the Affordable Care Act.
Yeah.
So I think that has us all, a bit on edge.
Yeah.
So you guys were talking about how there are limited services available for adults with autism, but are there any specialized services available for seniors, or do you find that's been an area of care that has been neglected for the most part?
That's a great question. So the good news is here in our backyard in Pennsylvania, there are two of the only programs in the nation that are focused on only 21-year-olds and older. And those programs are serving seniors on the autism spectrum. And so I think we are in a place of generating a brand new set of evidence and understanding and clinical professionals who are top-notch at problem solving and having to work through these issues without an evidence base because we have not generated it for them. There are some initial studies that suggest interesting trends in how some of the co-occurring medical and psychiatric diagnoses change as autistic individuals age. We know that autistic individuals in general have the same lifespan as the general population or the non-autistic population. And so it's important that we prioritize that work Here at Drexel, we were just awarded funding from the National Institute on Aging to supplement our work focused on transition age youth and adults on the autism spectrum to extend into not only Medicaid, but also Medicare, and the way that that system is serving older adults. And so that's a good indicator that you'll be seeing more from us on that front very soon.
Yeah, I should mention it. I guess it's obvious, but seniors who qualify for Medicaid autism services are also going to qualify for Medicare. So they have two sources of coverage. I also wanted to pick up on the question of the possible invalidating of the ACA. In addition to Medicaid, the individual policies available on the exchanges would no longer be available. And many states like Pennsylvania have mandates for coverage through private insurance. So for those people getting individual policies, that could also disappear as well.
And Rob, the requirement for coverage until 26?
That would, well, depending on the ruling. If they invalidated the entire law, then that would go away in addition. That's right.
So that could be a key source of at least healthcare coverage for transition age adults.
Yeah.
As well. So
Yep.
multiple impacts.
Yeah. Now the court could invalidate the whole law, or they could just invalidate part of it. The individual mandate part, which basically no longer exists anyway. So that would be something to watch.
Hi, thank you. My question is, have you noticed a significant change in services provided in urban areas compared with rural communities? And if so, which area is performing better, and are there lessons we can learn from that?
Sure. There have been some research studies that have looked at, for example, county variation in both prevalence of autism as well as some aspects of service delivery. There are some really interesting projects that have been funded. For example, in Pennsylvania, we are fortunate to have both rural, urban, and suburban areas, and some of our partners at Penn State have been funded to work on interventions related to community participation in rural areas, which is very exciting work because obviously issues in navigating communities and accessing providers do look different, as you pointed out, across concentration of where people and those medical professionals and behavioral health professionals are located. I've not seen above and beyond the wider set of recommendations for incentivizing and further seeking to diversify and amplify the supply of service providers in rural areas. I've not seen autism-specific policy recommendations on that front, with the exception of applied behavior analysis for children.
So I'm actually an attorney in Wisconsin, and I run a biotech company called NeuroPoint DX, and we've developed the first blood test for autism based on metabolism of the child. I also have a 24-year-old son with autism, and I can tell you that Medicaid and private payers make it really difficult to pay for diagnosis, counseling, and treatment services, regardless of the fact that Autism Speaks has fought very hard to get 48 states to provide this kind of legislation. And I'm just wondering what you see as a legal recourse for both providers of services as well as patients like my son when they're not getting reimbursed, because I'm seeing that most often our test is not being reimbursed, and I know that out of pocket I've paid for lots of counseling and treatment for my son over the years and has not been covered by insurance.
I know in Pennsylvania, there's an organization called the Pennsylvania Health Law Project, which specializes in Medicaid eligibility and coverage litigation. I don't know what exists in other states, but you might want to contact them and they might have suggestions.
Yeah, and the guidance from most states that have passed insurance mandates is the insurance commission in each state is required to track individuals who submitted payments to private insurance and were denied. In Pennsylvania, we actually have a website that has information about Act 62, which is our health insurance law, and it includes sample letters for filing an appeal to the insurance company. But the primary way that the state tracks issues related to the law is through complaints to the insurance commission. So by all means, I think an agency like the Pennsylvania Health Law Project would be a conduit to filing a complaint in exactly that way. But in other states, a direct parallel may be to visit the website for your insurance commission, because they're often charged with enforcing the private insurance mandates. I think, just as a side note, as I was looking over slides and preparing, I sort of felt like we should have named our presentation, we need to change the landscape of Medicaid for individuals in the autism spectrum, because as much as I think we've provided you robust evidence today that this system is important and doing a good job of enrolling individuals who really need coverage and services, we still have work to do to try and make sure that the evidence base is fully boosted so that the right services can be on the Medicaid books to be reimbursed and required. So I think there's a lot of effort that we need to put into that from the research community. And one really dynamic way is to do it in an interdisciplinary way with legal professionals as well. So thank you for your comment.
Well, thank you so much, Professor Field and Dr. Shea. We really appreciate you sharing with us today.